do have uh, this study has also permission from the pharmacy board. Uh, Everything that goes through them, so they know that we were doing this study. But now the question is, outside of the study, what are the prescribing regulations? And that was the first stumbling block that we hit when we came to the point where saying we're scaling up. In fact, we're training nurses and clinical officers in some of the outlying facilities. But certain county hospitals do not allow uh, nurses to prescribe fluoxetine. They allow, treat, but not fluoxetine. So, and this changes depending on where you are so much that depends on the pharmacies. So we are in this situation where we are trying to find out how much they can change because we have regulations that are allowed nurses to prescribe uh, a more dangerous substance with more side effects. And we hardly had any severe adverse events. We didn't have any. We may have had some minor side effects in the beginning, but no severe adverse side effects with our participants. So actually, that is the place we are at. We're in the process of negotiating, and we may have to take this to the pharmacy and points on the board to this division of mental health, of course, to discuss these regulations because some county hospitals, some county facilities have no problem. So it really changes. And that is why we found when we were doing this study that even when we ran out of load setting, we were able sometimes to get them from other facilities because even when they get them because they are on the essential list, they're not able to use them. So I hope that answers that question. There was a question about why combine CFP and depression. In the statistic from yeah, actually, I've find that a lot of so that will also be coming of what group more than the other. A lot of And one of the reasons that we decided to do the study on flow on depression and PTSD is that a previous study which was done in Kisumu, so that there was a lot of comorbidity between PTSD and depression. And Dr. Ogeri, who maybe another microphone, can you chime in, Dr. Ogeri? Or you come up because you were in the previous mind study, which informed this study. Yes, yes. I can also talk about why we did not compare treatment as usual, which was another question. Now, the question of if you're going to design a study with treatment as usual, what is treatment as usual in a place like uh, Kisumu County? When we started this study, there was no psychiatrist in Kisumu. We had a ward, but no outpatient facility. The outpatients used to go to UTRH. Those who don't know what UTRH is, it's Jaramogi Oginga Odinga Teaching and Referral Hospital. When you work here, you learn to call it UTRH. So that was where the outpatients used to go, and the inpatients used to come to Kitumu County and Referral Hospital. We have uh, uh, psychiatric nurses, and maybe some of them are here. Raphael is here. You can talk to him later, or you can say something. So treatment as usual. How would we have managed to get 1,000 uh, participants to be treated under treatment as usual? That is the reason why. I'm told to wrap up. There was some question about severity or something which I really did not get. To the request the person who has Yes. Okay, thank you very much. So you can get in touch with me. Okay, just patients who had only depression and patients who had PTSD alone. That is part of our sub-analysis work that we're going to do. Thank you.
Okay, Stella, maybe now you can respond to the question directed to you.
Yeah, I'll start with the question of sustainability. How are we making sure we are sustainable? Remember what I said is one of the facilities that was running when we started, that is 2018 and before, was run by organization. That means that if they walk away, we our mental health services. So what we need sustainability. One is staff redistribution. I talked about the clinicians who have done psychiatry who are not doing normal duty, psychiatrists who are not doing specialized duty. So that is government employees running these 27 clinics. So we are assured that the clinics are going to be there in terms of service delivery. When it comes to commodities, by the fact that we have this data, we were able to demonstrate why we need commodities like psychotropics. So we have all these services being supported by government. So the partner can plan, and that is why we plan together. So that you don't come as an NGO and say you want to do this kind of intervention. And maybe Professor Madai can attest to that when they wanted to do a study and we say, we want the skills to be led. And we have trained even the 100 clinical officers trained on MHGAP was through a study by a partner. So for me as a lead, I'm very key on sustainability. When you're doing an intervention, are we going to be led with that skill? So with that, I think we are very well covered. The other one is the question on indicators, Dr. Ongeri. I know the ministry is currently, even as we sit now, they're doing the indicators. They started about a few months ago. For us as a county, we developed our indicators in 2021. So what that one means is that because we are the one in the dashboard, we just do adjustment and ensure there is either we do interoperability, that it can fit, and even as the national move to the new system. So those are the conversations once they have the indicators in the KDHIS or move to the new system they're talking about. Is our dashboard going to be interoperable, or can we revise our dashboard to be able to capture the indicators as per the MH? So that's a conversation that we will have because we already have. The other one was on political support. In advocacy, remember one of the things you want to do is change either policy, regulation, or the mental health, the services. So one of our biggest support we have is number one, our current governor has mental health as during the campaign was one of the areas. So we know for the next 5 years we have a political support from the legislative. Number two, what we have done, we have gotten one of the MCA is a champion of mental health. So currently, as we do our mental health action plan, he's pushing for a mental health, Nairobi County mental health bill at the assembly level. So with having a champion at the legislative, what it assures is that when it comes to budgetary allocation, for us to be the CIDP, we are covered. We may not be where we want to be because we want to talk about ring-fencing of the mental health budget. We may want, from the current 2.5, our budget is about 60 million what we work with. But the fact that we have the ear of the governor, we have the conversation about mental health happening where decisions are made at the county level, the executive, and also at the legislative, we have the political goodwill. And that is what we work with. Thank you so much.
Quickly to my tools or validated. One, champions. It's a lot of work. We need to have people who are interested in putting in all the work, people who are willing to put in the hours. Unfortunately, they have been very few. We also need resources. It is a research. It will require someone to put in the work and they need to be compensated. And unfortunately, the focus has not been on validating on developing the tools. But then why even develop? Why reinvent the wheel? I think the people we need are people who can take tools that have already been developed and are appropriate, then do some validation and reliability studies on them. And we are not seeing as many people, but I'm hoping that we are sitting here with young people and many of them are willing to take it up. The second question is on okay. It is, in my view, at level one, at the community level, and yes, it fits in with the current government system of, if you think about healthcare structures, And in there's a level 2 facility, there's a clinic officer where if the youth sees like a suicidal patient or someone who is depressed is passed there. Unfortunately, it's not 3 or 4, so they end up coming to MTRH. And for any of such a setting, then it will be upon the team to establish what the referral path will look like. But yes, they fit it. And we hope that if you look at the Gigatojo pyramid, community level, mental health is highly encouraged. Asante.
Okay, we are